During this influenza season, it's important that we continue to wash our hands regularly, wear masks when appropriate, and make sure that we and our loved ones get the influenza vaccination or flu shot this year. Our topic on today's Health Talk is influenza prevention. We'll also discuss the symptoms, diagnosis, and treatments for flu. So stay tuned for an informative show. We're up next. Hello, I'm Dr. Eric Mazur. Welcome to this week's Health Talk. Today we're going to discuss the seasonal flu because we're receiving a lot of information about it. We're also fortunate to have Dr. Benjamin Greenblatt, chairman of the Department of Emergency Medicine at Norwalk Hospital, as today's guest. Welcome to Health Talk, Ben.
Hi, thanks. Thanks for having me back.
So we're going to talk about influenza prevention, but the whole gamut of influenza. But this year it's a little bit special, isn't it? Because we're also in the midst of the COVID-19 pandemic. So tell us a little bit, maybe introduce, well, how are these two overlapping? Why is it more important that we deal with influenza prevention this year than ever before?
Well, it's always a good idea to get your flu shot every year. So, it'll prevent you from getting the flu. And if you were to get sick, even the symptoms you'll have will be decreased when you get it. But this year in particular, with the concerns around the strain on the healthcare system, we want to make sure that anybody that needs to come to the emergency department or to the hospital has available resources, whether it's PPE or room available in the
or doctors to see you, or nurses available.
Exactly. So,
and you can get overwhelmed, can't you?
Certainly, yeah. So a lot of emergency departments have, we don't have a lot of margin for, operational expansion. So we any small surges, that we tend to feel those. So we want to just preserve as much of our staff and our resources as we can. And I think getting a flu shot and socially distancing, wearing a mask and washing your hands, is going to be going to go a long way.
So let's talk about influenza prevention. What can people do to prevent it? Now, you mentioned the flu shot. A lot of people say, oh, that it didn't work, or I got the flu anyway, and it doesn't work 100% of the time. But you also alluded to the fact that people who have had the flu shot may get a milder case. You want to say something about that?
Right. I think, there's a lot of misconceptions out there that the flu shot will give you the flu, or, with the exception of some very rare conditions, like I'm thinking of Guillain-Barré or something like that. There's very no contraindication to getting the
And the flu doesn't give you the flu. It's not a live virus, is it?
Correct. So, I would recommend it. Sometimes you can get some soreness at the site. You can get some muscle aches. Some people get a low-grade fever, but it's not the flu. So it's just a normal response that your body has to it, and it's protective.
Yeah, and so starting off, everybody should get the flu shot. I'm sorry.
Yeah.
And how about when? When should they get the flu shot?
The recommendation from the CDC is early, is really by October and on. I mean, I know there were some places that started sort of towards the end of September, but certainly in October you should start getting that. I know the city, Norwalk City, started their own vaccination, and we were part of that. We've already had our flu clinic with the city. So
if you're watching the show and you haven't had your flu shot, you're already late.
You're already late. And there's plenty of places to get it done. So there's your primary office, there's CVS, there's urgent cares. There's a lot of places the city can sometimes, depending on where you live, can help to provide this vaccine. And
you actually were involved in a special mission which gave flu shot free of charge to citizens here in Norwalk. Do you want to say 2 words about that?
Sure. Yeah, that was just a great initiative, and we had about 200 free flu vaccines that we gave, and we organized ourselves. And I just wanted to give recognition to Jim Brubaker, who's our EMS director, Bob Bepko, who's our pharmacy rep, and their staff who came out. We set up in Norwalk, and we vaccinated close to 200
And that was something
people.
We've never done before.
We've never done that before, and that's a great community service that we did. There's no charge for it. We didn't ask really names at all, and we were able to get people vaccinated.
And I know you're doing something different in the ED now too, in the emergency department. When a patient comes in, you're actually offering them the flu vaccine, aren't you?
Right. That's traditionally something we haven't done much of in the emergency departments, with the exception of tetanus. Somebody may recognize if they've been to the ED with a cut or something. But but flu vaccination, we started that at the end of last spring. As COVID started to pick up, and this year, we've started to push to have that done in the ER.
And how have people received that? Have most patients been saying, sure, go ahead?
Yeah, no, it's been very well received, and it's really convenient for them. I think a lot of the time, if it's not a cost issue, it's a convenience issue. It's that they have to leave work or go somewhere, or they can't get childcare. And if you're here already, and we have and we can do it, we will do it.
And I think that's a great service to the community, and certainly for people at home. If you are offered the flu vaccine and you haven't had it, please take it. It doesn't make any sense not to get the flu vaccine. So well, tell us more about how are you preparing then for this upcoming flu season in the ED?
So, we have a, it's overlapping. I think one of the concerns we have is this, what some people have described as a twindemic. We don't want to, have a situation where we have, overwhelming flu cases and overwhelming COVID cases come to the emergency department. It's going to be very hard to distinguish. And what we are doing is we actually have a surge plan. So the hospital, we've been working on this probably since mid-August, recognizing and that this may happen, what's happening now, this uptick. So we continue to have, and we've kept our forward triage tent, which we have. We've never taken that down. We're not using it, but just in case we need to.
And what does that mean? Does it?
Yeah, our forward triage tent is something that we had to use last spring, and when the COVID cases were very high and we didn't have capacity in the emergency department to see patients, and we were concerned about using PPE, it was a way to decrease utilization of PPE.
I mean, were you able to send people home from the forward triage tent? Was that the idea?
Exactly.
Or admit them directly from the forward, or both?
Well, so we had criteria. So if they were healthy enough and we did vital signs and their oxygen levels were normal and the vital signs were normal, but they had some symptoms that were suggestive, we were able to take care of them there and send them home. If not, if they in any way didn't look well, or their oxygen or their vital signs were concerning, they went into the emergency department. They were still seen.
So this was literally a tent that was set up outside?
It's like one of those party tents that you see. It's 20 feet by 20 feet, and it was arranged great. It was a great setup, and we actually did some tele-triaging through there.
Can you use that through the winter? Can it be kept warm enough as we go into the winter months?
Actually, it has a thermometer and has a heating source. It has a big giant propane tank in the back, and I was surprised actually how well it worked.
So this was a way to actually get more capacity, at least physical space, I shouldn't say, but you still had to staff that.
We had to staff it, but we didn't need the intensive staffing that you would need in the emergency department.
So if somebody was really sick, they just get sent back right back to the ED where the docs and the people can care for them.
So that we could have a tech, a emergency department tech in the tent. Registration would be back in the emergency department, or it could be out there. And then what we had is a setup where you could have a telemonitor in there, and you could have a doc or a PA actually see the patient. So again, decreasing the risk of the provider getting it, and decreasing use of PPE. We had to be creative.
Question at home from patients, I'm sure, is why in the world would I ever go to the emergency department with all those sick people? If I don't have COVID already, isn't that going to give me COVID, or the flu for that matter? Maybe you could give us some of the facts behind how well people have done, both the staff and patients, in terms of catching COVID in the healthcare environment.
Right. So, we were fortunate, in all the cases and thousands of patients that we saw since last spring, we only had one team member, one of our team members got sick. But other than that,
Say that again, because I think that's really remarkable in terms of, how many people would you say work in the emergency room? 100, 150?
Exactly. So,
and one out of that whole group
in months of taking care of patients got sick.
And that's about, just again for folks at home, that's 1% or less, which is about how many people in the general population have gotten COVID.
Absolutely. So, I think what the community needs to realize is that we have a bunch of processes in place that put you into the emergency department as safely as we can. So we have a distinct area of the emergency department that's considered a hot zone, which is a best
Do you have
practice.
that right now? Is that
We
even?
still maintained it. We maintained it the entire time. Patients come in, they have a single room. So it's not like some of the emergency departments where you go in and 2-3 patients in a room. So it's a single room. We close the door, and we have a lot of different, we have plenty of PPE that we can use, and we have all the protocols in place to make sure everybody's safe.
Yeah, use the special N95 masks when you're in there. Do patients get those as well when they come in and they're
They get a surgical mask, which I can just show them right here. So it's a regular surgical mask. So if you come in with your own mask from home, you will be asked to put on a surgical mask, and you'll keep that on. And we ask that you keep that on the entire stay. And if there's any family members with you, they'll keep that on as well.
Is a surgical mask better than the cloth mask that people use at home?
We think so, and I think the direction we've gotten from infection control is that this is the ideal mask to wear when you're in the hospital. So
yeah, I've read that too. That multiple layers that are available in surgical beat sort of the I don't know, neck things that people pull up and just have a single layer of fabric over their face.
Yeah. So and then we'll use goggles or eye protection, a face shield if we need it. If you can't wear goggles, a surgical mask, an N95 if we have a high suspicion, and people wear bonnets and gowns and double glove.
How about for the patient that doesn't have COVID symptoms but needs to go to the emergency department? I guess one of the very unfortunate consequences is, I understand, fewer people with stroke, fewer people with heart attack are showing up in the emergency departments.
Right.
How are they protected? Why should they not be frightened to avail themselves of their healthcare system?
Yeah, we've gotten that question before, and I think one of the things folks need to know is that there can be a risk to stay at home. So one of the things, working with our EMS director, we looked at some data going back, and the number of dead on arrivals when people call the EMS or 911 system had quadrupled from the year before.
This is here in the Norwalk community,
right? So these are the cases of people waited too long.
So this is I'm sorry, just so I understand. So these are the EMS got to the person's home, and they're dead.
And they're dead. So those that we get these calls, and
quadrupled.
Had quadrupled. So and also we had gotten calls in the emergency department. I know I'd taken a call once from a mother who did not want to bring her child to the emergency department. This was at the height of it because he was having an allergic reaction. She didn't recognize how severe it was until I actually heard the kid in the back with a raspy voice saying he couldn't breathe. So at that point, I had to convince the mother that we will bring her right into a room. I would be there. And but those are some of the measures we take. We just bring patients into a separate area of the emergency department. They have their own room, and we protect. Everybody wears gloves going in. They wear a face shield. They wear a mask.
The patient wears a face shield and a mask?
No. Come
into the room.
The doctor and the nurse. So I think in a lot of ways you're safer than if you're out and about, in the community where people may not be, taking it as seriously.
And again, just to emphasize, the emergency room personnel, the workers, the doctors, the nurses, the techs, they walk the walk because they're in the emergency department all day or all night, and they did not get sick.
Right. So there were 10, we're there 10, 12 hours or longer, and they practiced, washing their hands after each patient, before you go in, after you come out. And if you need to change your mask, you change your mask out if it gets soiled. So we were very.
So this stuff, I think that's a really important and optimistic message. It's almost getting cliched now. Wash your hands, wear a mask, stay socially distant, but this stuff works.
It does.
It really works. It sounds too simple. It sounds perhaps a little awkward, but it really works, and it's kept your whole staff healthy during this COVID epidemic, and it can help keep the rest of us healthy as we hopefully don't, but as we approach perhaps a second spike.
Yeah, I think, talking to my surgical colleagues, one of the things we found out was that, people presented later. So, with perforated or appendicitis, for example, or gallbladders that were, very inflamed, that should have come to the hospital really much earlier.
This we're hearing about all over the country. We've got to take a break right now for a couple of minutes, but we'll be back in just a moment to speak with Dr. Benjamin Greenblatt. He is the chairman of the Department of Emergency Medicine at Norwalk Hospital, and we're talking about a very timely topic, the flu and COVID-19. It's something that affects us all. We'll be back in a minute.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
Hi, I'm Dr. Eric Baser. Welcome back to Health Talk. My guest today is Dr. Benjamin Greenblatt. He's chair of emergency medicine at Norwalk Hospital. We're talking about COVID-19 and the flu, why it's important to protect yourself against the flu this year. Let's talk a little bit more about the flu itself, because a lot of people don't quite know what the flu is. I think we use that term a lot. It's gotten kind of a generic meaning of a viral disease. But influenza is a real disease with a specific germ, specific virus. It's really not a germ. Tell us what is the flu?
Well, as you mentioned, I mean, it's a viral illness. There's subtypes. We're used to thinking of, the different influenza A and B, which are the predominant ones. There's H1N1 that's still circulating in the community. And over time, it can change. It can mutate. So you can have different genetic types of flu.
And that's why we need the flu vaccine every year. A lot of people don't understand that. But
I think that's been a goal of medicine, is to try to get a universal vaccine that would be the same and it would treat you it would take care of you for the rest of your life, like we have.
Well, it's different than polio, for example, which doesn't mutate. So you get the polio vaccine and you're fine. Where flu, every year it comes back in a different disguise.
Exactly. So we have that drift. We have some idea, when it starts to appear in other parts of the world, and it's a race to get the right, vaccine.
It's a little bit of a guess, though, isn't it?
It is.
I shouldn't say it's an educated guess.
And it is, and in some years it's more effective than other years, and we'll see, and you will see that, and we'll feel that in the hospitals.
I know a lot every year. I guess I don't know who determines what combination of antigen or disguises they're going to immunize you against. Do you know that sometimes they mix them? Do you know this year how many viruses the vaccine contains?
I don't. I know we use a quadrivalent.
Oh, okay.
So I would have to say 4. So we use the Fluvarix one. So that was I think 4 subtypes. So you'll be protected against those 4. So.
I mean, I've also read that older folks like myself, they sometimes will give a higher dose to sort of boost an aging immune system. Is that something you're doing in the ED also, or is that more out in the community?
That's a good question. So, I think what a lot of patients may not realize, or the public, that there's actually multiple manufacturers of flu vaccines. So, the one we're using uses just the same dose. So depending, you have to ask your doctor what vaccine they're using. And whether
there's no right answer to this either, I guess.
Right. So we were fortunate in the sense that the one we're using, it's at 0.5 mLs. Whether you're 6 months or older. Mm-hmm. So the pediatrics had a little bit of a wrinkle there. If you've never had it before, you had to have a second dose at the 4-week mark. But other than that, it was the same dose, at least with this. And I think that's the advantage of using the one we're using.
Uh-huh. And tell us a little bit. What are the symptoms? How's the flu different from a cold? What are the symptoms of a flu? The typical symptoms.
Well, I think the typical symptoms that we're used to hearing about is, that sort of, high fevers, cough, congestion, muscle aches. Your sort of bones feel they hurt, and fatigue. So I think that sort of distinguishes. You just feel wiped out, and I think people we see them in the emergency department. By the time they hit the emergency department, they feel awful, and they just feel like they're
I've heard that flu hits you like a Mack truck. That you're well, and then you're. Whereas again, I haven't seen patients with COVID. I've heard that tends to be a little bit more gradual onset. Is that true?
Well, what we were seeing is that by day, really by like the 6th to the 10th day, that's when people came in. After having COVID symptoms, right, with COVID.
Whereas flu, 6 to 10 days, you're usually done with it.
I think you're probably recuperating at that point. If you haven't already had some type of treatment early on in the flu in your disease.
Well, I know that both flu and COVID affect they're primarily respiratory tract viruses, and we have tracheobronchitis. So cough, shortness of breath, flu can get down in your lungs as COVID can to cause a pneumonia. I know people can have GI symptoms, but they're not primarily gastrointestinal viruses, right?
You mean for COVID or
COVID or flu? I know
I think one of the interesting things about this whole last year is really learning about this. So I think some of the first cases in China, and I can remember, I have a friend who's an ophthalmologist. Was conjunctivitis can present this way, and then the gastrointestinal symptoms that you had, the loss of sense of smell,
that seems to be a pretty specific symptoms for COVID, doesn't it? This loss of taste and smell.
Exactly. So that really helps. If that happens, then you should really.
Yeah, I read that about 85% of people will get a loss of taste or smell, and that's a very useful. If you do have that, and you've got some aching, definitely see your doctor.
Yeah, absolutely. So,
And so we're talking about other symptoms of the flu. Now, we also have treatments for the flu now. So tell us a little bit about those. When do we treat the flu? What do we treat it with?
yeah, we have some antivirals. Tamiflu is sort of the trade name, and what we have, it's tough because some patients may try to tough it out a little bit, and then by the time they present to the emergency department or to their primary doctor, to an urgent care, they've already had symptoms. So usually, the faster you get it on board, the quicker. But generally by 48 to 72 hours, the benefit starts to decline.
And this is really important to emphasize for people at home that this has been tested. This Tamiflu has been tested, and it effectively helps to attenuate flu, but only if you give it within 72 hours. And beyond that, as you said, it's not even recommended because
Right.
the disease. So people should really seek help early, right?
Yeah, it's a tough thing, because some patients may not recognize and maybe early on in the disease, and they may think, hey, you know what, I'm going to be better by tomorrow or the next day, and they're actually getting a little bit worse. So they don't want to come in too early to get it. At the same time, if you wait too long, then you're out of the window for treatment.
Now, how do you make the diagnosis of flu in the emergency department?
So we do have a rapid flu test that we can do. It's a very accurate PCR test that we use here in the hospital. It takes about an hour to do it. So and then there's a point that you do reach when there's there's enough flu circulating in the community where you would just treat everybody with presumptive symptoms for presumptive flu.
Do you treat everybody who walks in with flu or who you believe has flu with Tamiflu as long as it's within that 72-hour window?
Yeah, only if they test positive. If there's, I think, I can't remember if it's 30-40%, prevalence in the community at that point, I think the recommendation is you just assume they have it and you treat them.
Is it going to change this year with COVID? Because now you're really trying, I know you could probably get them at the same time, but will you use a positive test for flu to rule out COVID?
Well,
how do you handle that?
That was a very difficult thing to do. We do have a respiratory infectious disease panel, which has a lot of different viral, but it's extremely expensive. And we were doing that initially. We were testing everybody with it, and that could tell you whether you had a cold, which you weren't going to do anything about, or parainfluenza, or the other subtypes of coronavirus. A lot of people don't recognize there's other subtypes, and then we would send off a coronavirus, COVID test, I should say, and maybe an RSV. So now we're working on really narrowing it down to the things that we could actually treat you for. So it'd be like a flu and a COVID test, and getting that test done.
And maybe we could talk a little bit about the testing, because again, people I think are more in tune and hearing more about testing than they ever have before in their lives, probably hearing a lot more than they want to know. But you mentioned you have a 1 hour turnover PCR test for flu.
Yeah.
First of all, without being too complicated, PCR is an amazing technology, maybe where you're actually detecting the specific gene for the virus. Maybe you could say a couple words about that. Because it's very different than antibody testing or antigen testing, which are pretty elegant in and of themselves.
Yeah, so PCR testing is extremely sensitive, as you know. So it's looking at really the DNA particle and being able to amplify that. So it's highly sensitive. So when you get a positive result with that, you believe that test. So it's a test that you can actually.
So false positives are pretty rare then with PCR testing.
I think what we were concerned with is at least with COVID is are these actual particles are these you're at a carrier state at that point afterwards, and you just have some viral particle left, and are you really infectious at that point?
Again, so for people at home, just to emphasize, these tests can pick up literally a copy, 2 copies of the gene of the virus, the DNA that's actually, what's COVID? Is it a DNA virus or the RNA virus?
The DNA of the virus?
Yeah, it's DNA. And they can pick up a single copy of that gene, and what they do is they put special chemicals in that amplify only that gene if it's there, and it comes out either positive or negative. But it's so sensitive that, as you said, if someone happens to have a particle right where you put the swab, but they're not infected, it can come back positive. So in that sense, it's a fault. That's why I think some of the controversy about getting COVID again has been so difficult to understand. Is this if you've had COVID, you may have some viral particles hanging around a couple of weeks later that aren't affecting you.
Yeah,
Go ahead, you can talk about it, because it's so
I
interesting.
think we talked about the immunity. You know, with a lot of diseases, you do get some immunity for a while, and just this is such a new disease, and we've been surprised on more than one occasion. With this disease, is really how long does we don't really know how long does your immunity last. So. We're not sure, so we presume that you have some. Is it 3 months, or are some case reports of people being reinfected, I think, as soon as 3 months? But there's not a lot that I'm aware of.
And it's because when we test for immunity, we usually test for antibodies, but there's other kinds of immunity in our body which may not be readily apparent, and yet will help maybe attenuate the disease if you get it again. T-cell immunity, but
Sure. Yeah.
now, in terms of the PCR test for flu, I didn't realize it was a PCR test for flu, so that's quite accurate. Tell us some of the problems in getting the same kind of rapid turnover test for COVID, because I know that that's been an issue, and people have talked about the antigen test for the spike protein, and also for the some of the antibody tests. Maybe you could go through those different tests for people at home so they understand some of the differences.
Well, I think the sort of the gold standard would be to get the PCR test. I know that there's some of the school systems are sort of requesting that as a test because they're more accurate. So what we would see is patients that may have not had that or had an antibody test could have false negative rates of 15%. Depending on on the technique or symptoms or where they are in the disease process. But if you remember that the turnaround times in these tests have been changing. So when we first started this, I mean, I can remember we actually had to get permission from the state to actually run the test, and then it had to be sent, and it took days to get back. So we've gone from days to really getting this test. If we really wanted to speed it up, we could run up to the lab and get it done in about 15 to 20 minutes, but typically about an hour in the emergency department.
So you're able to get an hour turnover in the emergency. So that's done locally, or at least within the system, done at the Danbury?
Well, Danbury. Well, we have a partner with, we use a Sonic lab that we're partnered with, and actually the tests that we're running, actually we just stopped using. We're actually doing it up in Danbury. You're right, the Cepheid test. So
now, if you go to your doctor's office, those are usually not the hour turnaround tests, right? They don't have. I know the emergency room patients have priority in getting these rapid turnaround tests.
Yeah, I'm not sure. Actually, I'm not sure. I know some of the urgent cares have some capability, but I'm not sure if what they're using.
Now we have less than a minute left, so tell us quickly the antigen tests and the antibody tests, which are often easier to do on site, but give you different information.
Yeah, so I think the antigen testing, it's one of these tests that's more readily available. It's a bit easier to run, faster to run, but doesn't give you the sensitivity that the PCR test will give you. We're waiting to get some better testing in that, and I think just like with any of these disorders, with this disease, as we're getting more and more testing, it's starting to improve. So we look forward to better and more accurate.
I'm going to have to stop it there. We'll have to leave the antibody test for another day. Yep. Thank you, Ben. This is just wonderful. Unfortunately, very unfortunately, we are out of time. I can't thank my guest enough, Dr. Benjamin Greenblatt, for joining me on Health Talk today. Please send your questions and comments. We're very interested in hearing from you. Please send them to healthtalk@newvancehealth.org. We'll see you next time, and stay healthy during this very unusual time.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.